ఏనా? I see. So today we'll continue intestinal obstruction, and as in the last class we were discussing about the various types of obstruction like dynamic, adynamic, and various causes of dynamic like intraluminal, intramural, and extramural, and the commonest being adhesions. So then there is a distension because of gas or fluid, and the patient will go into dehydration also due to various causes. This is closed loop obstruction where external forces will block the lumen, or intramural like carcinoma of the colon can also cause, provided the ciliocecal junction is valve is competent, then this will become a closed loop, and various causes. So now the classification being acute, chronic, and sometimes we add subacute also, and depending upon the level of obstruction, it may be small bowel high or low small bowel obstruction or large bowel obstruction. Then there is complete or incomplete. Then these four features we should always remember: pain, distension, vomiting, and constipation. And depending upon the level, high bowel obstruction, it will be vomiting will be there mainly, whereas in the low small bowel it is pain, large bowel it is distension and constipation. So this is the visible intestinal peristalsis. Then patient may also have dehydration, tenderness, and sometimes it will lead to strangulation. So strangulation is nothing but the bowel becomes ischemic as bowel supply is compromised. So the strangulation can be again by external pressure, like in obstructed hernias or adhesions, or due to interrupted mesenteric flow as in valvulus and intussusception. And there in a closed loop also there is pressure on the valve so that its blood supply is decreased. So this is the problem will be more pronounced in elderly people. So strangulation, the main thing is pain is the not intermittent as in subacute intestinal obstruction. It is continuous pain. Patient will also have added shock also. And for external obstructed hernia, say this word you should not forget, tense, tender. Okay. And so this is strangulated hernia with purple colored skin. Investigations, we depend mainly on plain X-ray, where already I have told you about valvulae conventis. Ileum, it is featureless, whereas cecum, you will have round glass-like gas shadow, whereas last bowel, it is haustral folds. So this is supine, whereas this is erect posture, wherein you are seeing the step ladder pattern and also fluid levels. So coming to fluid levels, two constant are there. One is duodenal cap here, and then another is at the terminal ileum. And whereas other fluid levels may be there around 2. If it is more than 4 means it is abnormal. So we can also give water soluble contrast to appreciate better, and CT scan nowadays is more and more used. You can see the fluid filled intestinal loop. So you can also see the site of obstruction before laparotomy so that we can plan better. So treatment is always first is nasogastric tube to suck away the fluids, then you have to give IV fluids, then antibiotic, anticipating infections, and how to relieve obstruction is the thing. So, but you have to delay the surgical treatment till you resuscitate the patient adequately. But there is a rider. There should not be any strangulation or closed loop obstruction. In these patients, the sooner you do, the better the prognosis. So surgical treatment is also delayed in cases of adhesions where conservatively you can manage up to maximum 72 hours. It may resolve because otherwise multiple incisions, this obstruction is mainly due to surgery. So once you are doing again relaparotomy, it will also add. So to minimize the number of surgeries and unnecessary, particularly because it may result within 72 hours. But early surgical intervention, already I told you, obstructed or strangulated hernia and what is called as virgin abdomen. That means previously no laparotomy was done, means the cause is a definite condition which needs surgery. Okay, like internal herniation also. So once you do laparotomy, what you have to do is give midline incision, long midline incision, because you never know the cause unless you do the CT scan or plain X-ray. So first thing you have to assess is what is the site of obstruction. So is it lower gut obstruction or a higher gut obstruction? Is it colonic or is it small bowel? All these things do matter because the treatment widely differs between these sites. For small bowel, you try to resect and then anastomose, whereas for large bowel, if resection is needed, you will do colostomy rather than anastomosis because the wounds may not heal and it may give way. Then nature of obstruction is also important. Is it benign or malignant, or is it any adhesions are there or like that? So if it is malignancy, you will do as much less as possible so that you can resuscitate the patient again and then do laparotomy at an appropriate time for a definitive surgery. Whereas another point that is important is viability of the gut, which we'll discuss in detail now. Then what are the principles of surgery? Once you have opened, what you are going to do? First thing is you have to know the status of the bowel. So then you will deal with the distended proximal bowel, because once you open and the intestines are out, it is very difficult to put them back in and then close the abdomen. So you have to deal with the distended bowels. Then what is the underlying cause? Already we have discussed about it. So first thing in small bowel, what you have to do is, first is you have to deliver the distended small bowel into the wound so that for detailed assessment. But in doing so, you should not compromise the blood supply so that there should be no kinking there. And once they are out, you have to cover with a moist swab. Swab means not small swab. You can call it a towel. Okay, moist towel you will wrap around the bowels. So once you have known that the condition is benign in nature and it is not strangulated, then what you can do is, first thing is for not only ease of surgery, also to reduce the pressure on the abdominal wound, as I told you earlier. It is very difficult to close the abdomen once you open. So then it will also reduce the pain, and then once the pain is less and once the distension is less, the diaphragmatic movement will be encouraged. So what you have to do is milk the contents in a retrograde manner to the stomach, wherein you have already instituted a wide bore Riles tube which will suck out all the contents. So this is very, very important step in intestinal obstruction of the small bowel particularly. So what you do is you have to, in a retrograde manner, you have to milk the contents, both gas and fluid, back into the stomach for easy sucking. So previously we used to use this Savage decompressor. Now it is only of academic interest because it will produce leakages. Because if you want to do with Savage decompressor, you have to give a nick on the intestine, which at all costs we should try to prevent. Okay. Now, if the problem is adhesions, it is simply adhesiolysis. That means we will cut the adhesions, sharp dissection you have to do. So this you can do by laparoscopic means, provided you know that the cause is adhesions and distension is not very much, the general condition of the patient is good, then you can go for laparoscopy. But usually laparoscopy we reserve for subacute and chronic cases rather than acute cases because of the used distension. So then hernia means first what you do is you reduce the sac and contents and then do routine hernia repair. Whereas if it is stricture, you will go for stricturoplasty, and if the strictures are very dense and then in close proximity, then you may have to resect that segment of the bowel. So benign lesions like lipoma, you will excise, whereas malignancy, as I told you earlier, we should not be in a hurry. We should not deal with the primary now. What you have to do is overcome the emergency by bypassing or proximal decompression. Suppose there is growth in the rectum, what you can do is you can do sigmoid colostomy. Suppose there is growth in the transverse colon, you can do or sigmoid or rectal junction, you can do transverse colostomy. Whereas sometimes you may be forced to do cecostomy also for ascending or hepatic flexure growths. Similarly, for ascending colon in the low down, that is around cecum, you may have to do ileostomy also. So like that, but don't deal with the malignancy in emergency. Okay. So this is one example of bands. See how they are obstructing the small bowel here. So this is example of bands. Then this is the stricture. This is the tuberculous mesenteric involvement. You will seeing multiple strictures. So here also another stricture. So this is tuberculous strictures. So now coming to the viability of the bowel. Once you see the bowel, what you have to specifically observe is the pulsations in the mesentery. So here, these vessels, they will be pulsating. So once they are pulsating, that means the bowel is viable. Similarly, the color. See the color here, it is pinkish. Whereas the color which I have shown already, that is, so this is the color of ischemic bowel, purple color. Okay. Then the sheen. Sheen means the shining. So you see this bowel, how it is. Whereas see this bowel, how it is. So it is glistening here. See, it's all glistening. That means this is viable bowel. Whereas bowel that is ischemic will lose its luster. Then peristalsis, and see, this bowel is actually there is other where there is no stricture like this. Here it is, there is peristalsis, whereas bowel that is ischemic will not show much peristalsis. Then the texture of the bowel also is very important. Once you palpate, it should be elastic. So, but once you are unable to decide, see in this case, this is showing definite ischemia. See this, whereas here it is you are not very sure. Is it ischemic or going to be ischemic, or it is going to recover? So in those cases, what you have to do is wrap the bowel with hot packs. This is very, very important for 10 minutes, and then ask the anesthetist to give 100% oxygen instead of oxygen 80% and nitrous 20%. You will give, ask the anesthetist to give 100% oxygen. So wait for 10 minutes, then reassess. So still if it is non-viable, then you have to resect and do end-to-end anastomosis. Once the general condition of the patient is bad, you may not, of course, if it is colon particularly, you will bring them out as stomas, both of them, in the so-called Paul Mucklick's procedure. Okay, so this is once again now, this is the table form of differentiation between viable and non-viable intestine. So viable intestine, as far as the circulation is concerned, it will regain the color back to lighter colors, whereas in non-viable it will remain. So I already told you about pulsations, no pulsations in non-viable bowel. Similarly, appearance also, it is shiny bowel, whereas here it is dull and lustreless. Then texture is firm and elastic, whereas here it is flabby, thin and friable, as I have shown the example. See, this here particularly, it is so flabby and friable. Okay, then peristalsis will be observed in viable bowel, but not in non-viable bowel. Okay, then let us go to the relook or second look laparotomy. If you are still in doubt, you are not sure whether it is going to regain viability or not, so you need not do resection, provided the patient's condition is good. Then you can wait and then do relaparotomy after 1 day or 2 days. Then you will assess. Once it is ischemia is established, then you will remove the bowel. If it is regained its sheen and viability, then you can go back and then close it. So that is the thing. Now let us go to individual problems. So adhesions and bands being the commonest reason for intestinal obstruction. Around 40% of intestinal obstructions are caused by adhesions. So the adhesions, in fact, usually form within hours of surgery. So you have done some laparotomy for some other disease, and they will start forming within 6 hours. But of course, early we call them as fibrinous, whereas late it is fibrous. So fibrinous example is, all of you, I don't know, but all of you might have experienced these pizzas, where in the advertisement at least I have seen, though I have not tasted so far. So these pizzas, the in between the two pieces, how the adhesions will be. So they are called as fibrinous. Whereas complete dense adhesions are called as, so these are flimsy, whereas these are dense, fibrous. So what are the causes for intra-abdominal adhesions? Once you open the abdomen, it is bound to adhere together. That is way of healing. So the things that will hasten or exaggerate the adhesions are anastomosis. Then, because always this momentum will try to cover wherever there is ischemia. So there's ischemia around anastomosis. Then raw areas. So in these things, adhesions will form because of acute inflammation. Then chronic inflammation, best example is Crohn's disease. Whereas infections like peritonitis are definitely going to produce. You have closed the perforated duodenal ulcer, then it is going to adhere. Then tuberculosis, even without laparotomy, tuberculosis is going to produce adhesions. Then once you do laparotomy, you are bound to instill talc, starch, all these gas pieces, silk pieces. So they are the causes for adhesions. Radiation enteritis is another cause. So these are the adhesions, what I mean. So here it is attached to the bowel itself, not to momentum. So these are the adhesions. So how to prevent adhesions is instead of treating, you have to prevent them. So first thing is good surgical technique. There is no alternative to good surgical technique. And of late, laparoscopy is because minimal intervention we are doing. So laparoscopy is another mode of preventing adhesions. Then another, we can instill so many substances. So that is what you can do is with copious saline or even ringer lactate. You can, but not dextrose. That is important. Then contact with gas. Frequent mopping with gas pieces is to be avoided. So then installation is very important, like hyaluronate solution, dextron, PBP, that is polyvinyl proline, and then silicone. All these things, they will delay the adhesion formation. So then, now bands are dense adhesions, mainly from momentum. So greater momentum to parietis. And congenital bands are also there, like the obliterated white intestinal duct, that is in continuity from the small bowel to the umbilicus. So bacterial peritonitis will also produce thick bands. So same treatment like adhesions. So what is the treatment? Already told you about adhesiolysis. There may be an opening, there may be multiple adhesions, but the one that is causing adhesion, this intestinal obstruction need to be cut. See, in the example I have shown here, it is not causing any intestinal obstruction. It's only simply the bowel is adhered to the parietis, that's all. It's not causing any intestinal obstruction. But there may be one that is causing the intestinal obstruction that you have to cut. Sometimes, I already told you about laparoscopic adhesiolysis. Sometimes there may be recurrent adhesion formation, twice, thrice you will open the abdomen. But sometimes what you can do is what is called as Nobel's plication. But nowadays we are not doing it because it is not much effective. So, but this is only for academic interest, and in your entrance examination they may ask you. So internal hernias, already I told you, just like external obstructed hernias, like femoral or inguinal hernias, there may be internal hernias because there are certain foramina or certain defects, like foramina of Winslow, where it is lesser momentum free edge is called as foramen Winslow. So there the bowel may go and then get stuck. Similarly, there may be defects in the mesentery, broad ligament, or transverse mesocolon, where the bowel may enter, may not come back. So, as far as possible, you have to close these defects. Once you have done with your surgery, you have to close these defects. Otherwise, there is chance for internal herniation. Similarly, there are certain foci, and so there, and even diaphragmatic opening also may lead to hernia. So here you should be very careful because on the free edge, as I told you, lesser omentum, there is a hepatic artery and portal vein. If you cut that, it will lead to unnecessary complications. So another cause is internal herniation. Then strictures, already I told you about tuberculosis, Crohn's, and malignant strictures will be there. Usually they will be either chronic or subacute presentation, not acute, unless it is a much delayed case. So the treatment is stricturoplasty. What is the stricturoplasty? When do we do it? So stricturoplasty is cutting the stricture across like this and then closing horizontally. I'll show you how we'll close it. So, but this stricturoplasty, if there are multiple strictures in close proximity, you cannot go on doing this stricturoplasty. Then what you have to do is resection and anastomosis. Suppose in this segment there are multiple strictures, so then you cannot go on doing stricturoplasty like this one. Single stricture you can. When do you do stricturoplasty is, one is the strictures are far apart, and second thing is the stricture is not closing the bowel to more than 50% of the lumen. Of course, here it is dilated. You should not take this. You should take this and then 50% of it. So this is to some extent you can do, whereas this one you need not do anything. You can conservatively with drugs, it will heal. So what is this stricturoplasty? I'll show you. So the stricture is like this. So what you have to do is cut the stricture in the long axis like this, so that you will make an opening like this. Opening is made like this, but you should not close like this. No, you should not close like this. Again, if you close like that, again there will be more stricture. So what you do is, you should bring this end and this end together like this. How it is brought like this. So like that, this is called as stricturoplasty. Okay. Hope you are able to appreciate. Of course, the pen is somewhat light, so you may not appreciate it well, but that's it. So then there is another entity called as bolus obstruction. What is this bolus obstruction? That means intraluminally there are some foreign bodies like gallstones, tricho, phytobezoars already in stomach, we have known about them. Then worms also, ascaris. So coming to gallstones, the elderly, because the duodenum is thin, there is erosion of large gallstone from the already the gallbladder and the duodenum get adhered together because of inflammation. Then the gallstone will erode the wall of the gallbladder and duodenum directly. It will go into the duodenum. Because duodenum is wider, it will slide into the distally into the at 60 centimeters from the ileocecal valve, which is the narrowest portion. I go on telling about this. So 60 centimeters, what it will do is, because it's narrow, it gets impacted. And then the patient will be getting recurrent attacks of small bowel obstruction. Of course, subacute mainly, because it will not obstruct completely 100% lumen. So this is what is called as Wigler's triad. This is mainly for academic and entrance purpose. So what is this Wigler's triad? Subacute intestinal obstruction, pneumobilia. What is pneumobilia? Anybody tell me what is pneumobilia? Yes. What is pneumobilia? Yes, we got an answer. Pneumobilia. First answer is by 4-1. It is air in gallbladder. To some extent, it is correct, not 100%. 4-8 has given clearly. Air in bile ducts, correct. Air in biliary system, actually. Air in biliary system, because some more answers. Gas in biliary, 143. Yes, all of you are correct. So there is air in the biliary system. This is because the duodenal air or bowel air for that matter will enter through gallbladder into the entire biliary system. So you what is called as pneumobiliary gram you will get. Okay. Then shadow on plain X-ray, you will see the gallstone in the distal, that is in the right iliac fossa, you will see the shadow. So these three form the irregular triad. So on laparotomy, suppose you need to do laparotomy, what you have to do is, yes, 143, what you say is incompetent sphincteroidi can also cause pneumonia. Yes, you are correct. This is one condition only I have told. For that matter, any intervention, like the gastroenterologist will be doing sphincterotomy, or they may cannulate the biliary duct. So then there will be pneumobilia. Similarly, stones passing through the CBD into the duodenum, what will happen is that is one of the evidence or signs of gallstones is the dilated common bile duct with air. So that is one indication. Now, anyhow, let us not sidetrack. So stone, what we do is, we should not open at that place where there is a stone. So because once you close that, it will lead to stricture. In urology, our dean sir might have told you, or he will be telling you that in stone disease in the urinary system, you should not open where there is stone is there stuck. So there we have to milk it proximally. So like this. Sorry, it's not properly working. So anyhow, So you have to milk them in the distal. So I will just show you in this example. So suppose this is stone. This is not, but just showing. So what you have to do is you have to milk it here in the dilated portion, and then crush it, because it is only biliary stone. It will not be hard. It will be very friable. So you can simply crush it in the lumen here itself. You can crush it, and then these pieces will just go. You need not open also the abdomen, this intestine. Simply they will go distally. So whereas in cases where uh, it is not possible, or you are unable to crush the stone, then you can open the stone, the intestine, and then remove the retrieve the stone and then close it. Okay, whenever you close the small bowel, it should be always transverse. See, like this, not like this. You should never close the intestine like this. Always it is transverse. Even though you have given a vertical incision, you have to close it transversely. That is very, very important. Otherwise, you will yourself produce stricture. Right? This is another example of bolus. See this, so many ascariasis are there, mainly because they are all, most of them are dead after anti-helminthic therapy. Suppose the patient is having hundreds of these, they will get stuck, not able to move distally. So what you have to do is, you have to give a, again same thing, you have to knead, you have to knead the tangled mass into the cecum. Here it is reverse. So it is not proximal, it is into the dilated cecum, so that they will be nicely passed through motion. But sometimes they may not be, then in that case you have to open and then remove manually like this. Okay. So now let us go to the other important aspect. This is interception. Already it is covered in your pediatric surgery class, but just it is worth repetition because it is very important, even for clinical and academic purposes. So here already you will be knowing that it is the proximal portion. Always this is always proximal portion will invaginate into the distal side, and most common in children where they start weaning. So 5 to 10 months age, and in Muslims it is 9 months, where they will be this Ramzan. That is so Muslim children around 9 months, uh, where there is this sorry, in Muslim adults it is this Ramzan fasting for 1 month. They will have this, and in children it is 9 months is very common, and most of it is due to no cause. Actually, it is the Peyer's patches hyperplasia. So primary, that means no cause can be detected. But one thing they have observed is prior URI, or that is upper respiratory infection or gastroenteritis, will be the lead point there. So then, coming to older children, it is the cause is either a Meckel's diverticulum appendix, or sometimes Enoch Conlin purpura also. Enoch Conlin purpura is a differential diagnosis, and it is a causative also for intussusception. Then in adults, it is the polyp, like Peutz-Jeghers syndrome polyp, or the commonest in older people is submucosal lipoma. Very important. So already you will be knowing that the inner tube or entering tube is interseptum. There is a middle tube. There is outer tube that is called as interseptions. Don't get confused with these two terms. So then in children already you know, and for that matter, the commonest variety of interception is ileocolipopathy. So then, so this is the outer tube intersapiens. This is the inner tube interseptum. This is the middle tube. So already we have discussed that there is a sausage-shaped lump, and this is empty. Right iliac fossa is empty. This is called as what? What sign? Can you tell me? What sign is it called? Right iliac fossa empty in case of interception because the whole bowel has gone here. Yes. What sign is it? Dancing sign. Actually, it is a misnomer. We should not call it dancing sign because here dance is not the, it is not actually dancing. It is, he is a surgeon. Dance is a surgeon. So dance as a sign. That is also, we should not say like that. So both 4116, you have to correct yourself. 128, yeah. Sign of dance, correct. But here D spelling, D should be capital because already I told you D is dance. His name is dance. Not, it is not our dance, kuchipudi or any other dance. It is dance is his name, just like my name is Subba. His name is dance. So sign of dance, not dancing, or you should write, yeah, pseudo kidney is for sausage shape. Sausage shape mass, it is pseudo kidney. Whereas what I have asked is the right iliac fossa is empty. That sign was invented by this person called as Dr. Dance. Okay. So the complaint will be recurrent pain will be there. There will be vomiting, and then characteristic one thing is red currant jelly. This is also academic interest. Then you have to examine between episodes because the patient child will not allow you to examine, and you may not appreciate all the sign of dance or sausage shaped mass or pseudo kidney as somebody has told just now. So then sign of dance. See here D is capital. That is very, very important. And PR, same thing. Red current you may see adhere to your finger. And so the differential diagnosis again acute GE or Rhinoxon in purpura, polyps. So you may take plain X-ray, but D signs you can see claw sign on bare minima, donut sign, how they will appear, I will show you. CT target sign, all these things we will see shortly. Whereas coming to the treatment, it is resuscitation, and you try to reduce it conservatively by a very minimum. It is possible that it will, in 70%, it will reduce. Only the remaining percent you have to give a transverse incision and reduce. Then also you have to reduce only. No need to resect and anastomose. No need. Only if it is irreducible, only when there is this infarction or strangulation or lead point, then only you have to do resection. For a simple thing, it is always reduction only, particularly in children. Okay, so this is what is called as donut sign. Our vadas, foreign, they call donuts. Of course, contents are not same. Shape is different. That's all. Shape is same. That's all. So donut sign on ultrasound, whereas target sign on CT scan. Then class sign, you can see typical class sign, see, on barium enema. And this is how you have to reduce the small bubble from cecum and ascending colon. Okay, so that's about interception. Now, lastly, we'll go for volvulus. So, what is this volvulus? It is axial rotation of bowel around its center. Volvulus, there is stomach volvulus is there, volvulus of the stomach. Midgut volvulus is there. There is cecal volvulus. There is sigmoid volvulus. But today we will concentrate mainly on sigmoid volvulus because it is not only common in our parts, it's also given in exams, just like interception, more commonly given than interception, this question, volvulus. Okay. So if it is volvulus is, it is turning around like this, both anti-clockwise. Sigmoid will anti-clockwise, whereas cecal it is uh, clockwise. So that is the difference. You have to remember both. So if it is turned 180 degrees, then there is luminal obstruction. Whereas if it is 360 degrees, then even vascular occlusion will be there. So already I told you about volvulus neonatorum, mainly midgut, cecal, sigmoid, and what is not given here is stomach. So secondary volvulus, after surgery, there may be adhesions or stoma around it. There may be volvulus. So what is the cause for sigmoid volvulus? So there may be bands or adhesions, overloaded, particularly in South India. Our people eat so much. That's why it's very common. In a place where I have done my PG, that is Kakinada, this volvulus sigmoid is so common because they take huge quantities of rice. So overloaded pelvic colon, narrow, long attachment of so narrow, long attachment of pelvic mesocolon, and I already told you about high residue diet and constipation. Another problem, particularly in foreigners, this problem is there. So rotation occurs in anti-clockwise. Sigmoid, you have to remember it is anti-clockwise. Okay. So in a picture form, I will show you how they will be. See here, adhesions. Adhesions at the apex of the sigmoid colon. If they are there, then it will rotate anti-clockwise like this. The bowel will rotate like this. Then overloaded pelvic colon. Long mesocolon. Some people will be having so long that it is so freely there, and then it will twist. Then narrow. This should be broad like this, whereas it is narrow here. So this is the picture of sigmoid volvulus. So these are the causes. So once again, worth repeating, that is band, overloaded pelvic colon, narrow, long attachment, and then high residue diet, then the rotation will be in anti-clockwise direction. So what are the features? They can present either as fulminant or indolent. Fulminant will be sudden, severe pain, and the patient will deteriorate rapidly. Early surgery is warranted. Whereas some particularly old people, it is insidious, less pain, late vomiting, because already it is colon, so there will be late vomiting. But in volvulus, distension is huge distension. It's very early, constipation is absolute. Very, very important. There is what is called as compound volvulus or iliosigmoid knotting. That means the ileum will twist around sigmoid column. This is also common in our parts. So what we thought as valvulus may be in fact this is just like in the gynecology, they will be telling you about the cord around neck. So here also, suppose the small bubble twists around this, then there is huge distension like this of sigmoid column. So that is the what is called as iliosigmoid knot, right? Now, so already I have seen an X-ray, plain X-ray. This is what is called as coffee bean sign. See, this is, I don't know how many of you will drink coffee. So this is like a coffee bean with the central furrow will be there. So coffee bean. This is the one side. This is, we cannot say which is ascending, which is descending now because it is twisted. Okay. So that is the coffee bean sign. Now coming to the treatment, you can try, provided the patient's general condition is good and you are not suspecting any strangulation. You can try sigmoidoscopy, even rigid. With rigid, it will untwist the valvulus. Then what you can also do is, after untwisting, you can put a flatus tube up to the sigmoid colon and beyond almost, because flatus tube will be around half meter. You can put it and then leave it for some time. If it resolves, what you can do is, in young patients, after an opportune time, you have to do elective sigmoid colectomy, because if you don't do it, what will happen is there will be recurrence. So you have to do, particularly in young people, you have to do sigmoid colectomy. Whereas in elderly, you will wait, because surgery you have to delay, because with comorbid conditions, prognosis will be not that good if you go on resecting. So, but in elderly also, if there are comorbidities and recurrent episodes are there, then you can do laparotomy and then fix it. But sometimes that fixed point may become lead point. So you can resect, provided you improve his general condition, right? Then if the conservative methods fail, what you have to do is, you have to do laparotomy. If it is viable, then you can untwist, then either fix it or resect it. Whereas if it is not viable, you should never try to untwist. Can you tell me why you should not untwist a non-viable bowel? Anybody? It's a difficult question, of course, but you can answer. Just I want to test whether you are hearing me or intently or not. That's why these questions, because you can, yeah. Why we should not untwist an ischemic or a non-viable gut? It's a difficult question, I do agree. So anyhow, I cannot wait more than this. So there is, very good, very nice. 4-8, reperfusion injury, very nice. Correctly you have said. So reperfusion injury will be there. That's why you should never untwist a non-viable gut. And then what you have to do is, after resection, you have to do either Paul-Mucklig's procedure or Hartmann's procedure. What are they? I will show you shortly. So this is how a sigmoid colon will be there before untwisting. This is a viable gut. That's why sheen is there, color is pink. Then the blood supply is nicely shown here. After untwisting, this is out. So now this is the proximal, this is distal. See, by clockwise direction you have to untwist. Then, so this is Paul Mikulic's. You will bring both ends into the surface. The proximal end as a colostomy, distal end as a mucus fistula. Whereas this is called as Paul Mikulic's procedure, whereas Hartmann's procedure is you will bring a proximal loop like this, whereas distal, that is at the sigmoidorectal junction, you will close it so that any mucus can be drained through the per annum. So this is Hartmann's procedure, right? So I think we have completed this intestinal obstruction. The next class, I think we'll go for carcinoma of the colon, right? So if you have any doubts, I'm ready or glad to clear your doubts or any comments if you want to make. You can make. There is still 5 minutes time for us. Okay. So yesterday I was correcting your papers. Of course, not all. I've corrected around 20, and only 5 or 6 people have answered the for the question correctly. That is this duodenal stenosis. I don't know why there is still confusion among you. Duodenal stenosis, I have clarified enough that it is post ulcer manifestation. Whereas all of you have written for duodenal stenosis about this infantile pyloric stenosis or duodenal stenosis in infants. I don't know. If it is in infant, we will mention it that it is infantile. Actually, the commonest problem already I told you is infantile pyloric stenosis, not duodenal stenosis. Whereas if we ask about duodenal stenosis, it is post duodenal ulcer. Okay, so you have to write the answer as vagotomy and GJ, or somebody has written highly selective and GJ, both are correct, but not duodenostomy or duodenojejinostomy. No, that is wrong. You will get 0 marks. Whoever has written duodenojejinostomy or duodenostemy for duodenal stenosis, please correct yourself in the final exam. If that question comes, you have to answer it as duodenal, that is vagotomy and this gastrojejunostomy only, right? Okay. Thank you.